Welcome, Medicos! Today, we're diving into a high-yield, clinical-grade explainer on reversing non-alcoholic fatty liver disease, or NAFLD. Whether you're prepping for your boards right now or just looking to optimize patient outcomes on your daily rounds, understanding the exact mechanics of fatty liver is absolutely crucial in today's metabolic landscape. Okay, here's our clinical pathway for today. We'll start with a sheer epidemiological scale of the silent NAFLD epidemic, meet our clinical vignette patient Sunita, and then break down the pathophysiology. After that, we'll tackle the diagnostic dilemma, lay out an evidence-based reversal protocol, and wrap up with some high-yield clinical pearls. Section 1. The silent NAFLD epidemic. So the true scope of the NAFLD problem is literally like an iceberg. I mean, think about this. 1 in 3 Indian patients currently has NAFLD, yet an astounding 90% remain totally symptomatic. Why is that? Well, it's because the liver lacks internal pain receptors within its tissue. It's biologically incapable of signaling distress until the disease has progressed way down the line. And this silence, it's exactly why it's now the 3rd leading cause of liver cancer. Section 2. Clinical Vignette. Meet Sunita. All right, since we learn best through cases, let's meet Sunita. She's a 36-year-old sedentary school teacher. Her BMI puts her in the overweight category. She's pre-diabetic with a fasting glucose of 108, and she presents with elevated transaminases, an ALT of 68 and an AST of 54. Combined with high triglycerides, her ultrasound confirms grade 1 fatty liver. Now, on paper, she probably looks like a routine case you'd see every single day, right? But here's where we really need to pay closer attention to the history. Patients often dismiss these vague symptoms as just stress or, getting older. But as clinicians, we've got to recognize mild right upper quadrant discomfort, post-meal bloating, and persistent fatigue as absolutely critical early warning signs, not just everyday lifestyle complaints. What's really fascinating here is how we can map these seemingly vague symptoms directly back to the hepatic pathophysiology. Notice the brain fog? That happens because impaired liver toxin clearance leads to a mild ammonia buildup that directly affects cognition. And that right upper quadrant pain? That's hepatomegaly, physically stretching the sensitive liver capsule. We literally have to connect these anatomical dots for our patients so they understand the real stakes. Section 3. Pathophysiology and progression. To formulate an effective treatment plan, we have to zoom in on the cellular mechanics. The pathology here relies heavily on the 2-hit hypothesis. Step 1 is the first hit, the fat loading phase. Basically, systemic insulin resistance causes excess free fatty acids to be delivered straight to the liver, resulting in simple steatosis. Then comes the second hit. Oxidative stress ignites an inflammatory fire, leading to mitochondrial dysfunction and eventually hepatocyte apoptosis, or cell death. So, the absolutely crucial clinical takeaway here is this. Pills cannot stop this first hit if the underlying insulin resistance remains completely unaddressed by dietary changes. You just can't medicate your way out of a diet-driven metabolic bottleneck. It doesn't work. And let's look at how this builds over time. Untreated simple steatosis eventually progresses to NASH, non-alcoholic steatohepatitis, where active inflammation really kicks in. If that inflammatory fire isn't put out, it leads to extensive, permanent scarring, also known as cirrhosis. And here is a massive clinical warning. Both NASH and cirrhosis drastically increase the risk of hepatocellular carcinoma. Section 4. The diagnostic dilemma. This brings us to a major clinical crossroads. Faced with a grade 1 NAFLD diagnosis, physicians are typically presented with 3 mental pathways. Path A is the quick pill route, just throwing UDCA or vitamins at the problem. Path C is the dangerous wait-and-see route, basically doing nothing and repeating an ultrasound in 6 months. And Path B is the evidence-based lifestyle route. Unfortunately, A and C are chosen far too often in practice. Let's break down exactly why those 2 common choices fail our patients. Waiting just allows the metabolic cascade to worsen insulin resistance, which actually increases type 2 diabetes risk by 5 times. Conversely, unproven pills like UDCA just offer a false sense of security while the root cause quietly continues to destroy the liver. Lifestyle modification, Path B, is the only scientifically validated path to completely reverse grade I and II steatosis. It fixes the actual root cause. Now, while you're initiating that lifestyle discussion, always screen your patients for these escalating metabolic red flags. Central obesity, indicated by waist circumference, correlates directly to visceral fat. Keep a sharp eye on fasting glucose, triglycerides, and blood pressure. And definitely don't forget hidden cofactors. For instance, women with PCOS have a 3 times higher risk for NAFLD because of the severe underlying insulin resistance.
Section 5, Evidence-Based Reversal Protocol.
Now let's write Sunita an actual clinical-grade prescription for lifestyle modification. We deploy a targeted 90-day reset built on 3 non-negotiable pillars. Pillar 1 is dietary restructuring, specifically aggressively cutting dietary fructose, like in juices and sodas, because that bypasses standard metabolism and converts directly to liver fat. Pillar 2 targets a 5 to 10% total body weight loss through 150 to 200 weekly minutes of aerobic work. Even a 30-minute daily brisk walk reduces hepatic steatosis entirely independently of weight loss. Finally, Pillar 3 requires aggressively managing concurrent dyslipidemia.
But in the real world of the Indian kitchen, just telling a patient to eat healthy isn't going to cut it. You need to be highly specific. Advise your patients to eliminate maida, packaged juices, and deep-fried snacks right away. Replace them with low-glycemic, high-fiber millets like ragi and bajra. And here is a fantastic tip for your practice. Prescribe 2 cups of black coffee daily. Not only does it remove liquid fructose from their diet, but black coffee is epidemiologically proven to actually lower liver enzymes.
Section 6, High-Yield Clinical Pearls. Let's synthesize this into some fast, exam-ready facts for your NEET PG prep and daily clinical rounds. High yield for the boards. Always remember your transaminase ratios. In NAFLD, the AST to ALT ratio is typically less than 1. If it's greater than 2, you should strongly suspect alcoholic liver disease. Remember, NAFLD is always a diagnosis of exclusion. You absolutely must rule out significant alcohol intake. Also, jot down this massive red flag. Patients can actually develop hepatocellular carcinoma directly from NASH without ever passing through cirrhosis first. And finally, when your patients inevitably ask you about supplements, guide them with actual science. You can confidently prescribe omega-3 to reduce triglyceride-driven fat. Vitamin E can be used, but note the caveat here. It's proven effective only for biopsy-proven NASH in non-diabetics. It is pretty much useless for simple steatosis. Meanwhile, firmly steer your patients away from UDCA, which is not recommended by guidelines for NAFLD, and avoid those unproven generic liver tonics entirely. We'll leave you with this absolutely crucial thought to share with your patients. Your liver is silent. Don't wait for it to scream. Look, grade I fatty liver is 100% reversible right now, today. But that metabolic clock is ticking. As a clinician, are you ready to intervene with lifestyle as medicine before the silence breaks? Thanks for joining us on this explainer, and we'll see you on the next one.